Hi, this is Jim Metz. You will find a copy of my flip chart in your materials for this course. I start off with the candle flame on the front. The candle flame has always been my symbol, and that's the reason why it's on all my slides and whatever. If you imagine sticking your finger into a candle flame and jerking it back as a reflex action, the body protects your finger even though the finger is not that important. Can you imagine all the work that it'll go to protect your breath, protect breathing, which is probably the most important reflex action that we have. If you look at this next slide, you'll find the tongue falling against the back of the throat. That's the classic view of apnea. And I show this it can be the epiglottis, but most normally it's the tongue. It could be the nose, it could be the sinus, it can be anything along the airway passage. But I like to talk about the tongue because that's what we can deal with the best. I take this flip chart with me whenever I go. If I go to speak to even a radio interview or a TV interview, and I always have it with me so I can show people what I'm talking about. If I want to talk to a new sleep physician, I have this with me. We have one in every room so that we can talk to people and explain what the problems with sleep apnea are with more detail than you can just with just by description. So we use this a lot in the office, and I feel it helps to increase your patient's acceptance of what their problem is. If you go into the next slide, you'll find two slides, one on the left and one on the right. The one on the right is the airway once it's been cleared by with the mandibular advancement appliance. The one on the left is coming from gastric reflux. In other words, reflux coming up into the back of the throat and causing inflammation. This is a big problem. It decreases the size of the airway. There's many things that we can do to help with that. And a lot of times you need to work with your ENT or your gastroenterologist to help you control the gastric reflux. But by moving the mandible forward, the tongue doesn't fall against the back of the throat and shut off the airway and create a negative pressure within the chest as the diaphragm pulls, which can bring up acid from the stomach. The number of people who have obstructive sleep apnea in the United States is very significant. At least 40 million people, and quite probably is considerably more than that. The thing is that very few of them have been diagnosed. It's probably less than 4 million people that have been diagnosed. So there's a large number of people out there to find. Every person probably has at least 5 or 10% of their practice that has some form of obstructive sleep apnea or upper airway resistance. Speaking of upper airway resistance, this is the gold article, and I would recommend you reading it. It's on the functional somatic syndrome, and it goes through what symptoms a person with upper airway resistance, which is many times not considered to be apnea, what kind of symptoms they will have. Then it shows what mild apnea has and what moderate to severe has. You'll notice that the incidence of headache is much higher in upper airway resistance or with classically no apnea, because without the oxygen dropping, it is not considered to be an apneic event. And many young people perfuse so well that their oxygen doesn't drop, and so it's not an apneic problem. So if you move along, you'll see the irritable bowel syndrome is even higher in upper airway resistance syndrome or no apnea than it is with even severe apnea. You'll see bruxism is much higher. You'll see depression is much higher. There's all kinds of things that go along with that. Onset insomnia is higher. So that helps give you credibility with the patient to say why you're pursuing what you are. If you take a look at the next slide, you'll see a person with an airway that's somewhat constricted, and they've had a lot of dental work done. That's the bruxism. That's the troubles with the with gastric reflux. It's all the problems that go along with obstructive sleep apnea. They tend to be the people that need the reconstruction. Well, when we move the airway forward with a Herbst appliance, there's one place there. If you look at it closely, you'll see the airway is considerably larger. This is the Herbst appliance. It gives room for the tongue to come out between the front teeth. It can spread laterally. It's easily adjustable, and the marks on the side allow you to keep track of how far forward you've protruded the mandible. The vertical dimension of occlusion is also very important. That's the part in the premolar area where the pads are that create the amount of spacing between the upper and the lower jaw. Symptoms of sleep disordered breathing can be quite significant. You can have snoring at night, you can have pauses in breath, and many times they're witnessed by the sleep partner. You'll see choking, recurrent awakenings, palpitations, nocturia, or going to the bathroom at night, restlessness. Hours of sleep tend to be excessive. The patient will wake up with a sour taste in their mouth. You'll have a rapid heart rate when they wake up, and there's poor sleep architecture. As with the incidence of sleep disordered breathing, the architecture tends to change very dramatically. In other words, they don't go through the normal sleep stages, and people don't get enough rest. They'll have a rapid onset of sleep. People should fall asleep in probably 7 to 10 minutes, where a lot of people will fall asleep almost immediately. You'll see the insomnias, you'll see the GERDs, you'll see too many dreams. You should really only remember the dream you wake up with, not ones all through the night. If you remember all ones through the night, you've woken up an awful lot. You have an elevated blood pressure in the morning, which is totally unusual. It should be lower and not higher. During the day, you have excessive daytime sleepiness, fatigue, higher blood pressure, depression, and irritability are very high. Irritability and anger management, I feel, have to do with just trying for the person to stay awake. They get angry to create adrenaline, so they wake up a little bit better. You wake up with a morning headache. You have impaired memory and concentration because you didn't sleep well. Auto accidents are high. The incidence of type 2 diabetes is high. You'll notice this is a family history of diabetes and hypertension. You'll see a scalloped tongue, worn and eroded teeth. You'll see medications for sleep, high blood pressure, type 2 diabetes. Look for all those inflammatory diseases. You'll see weight gain and neck size increase. And again, you'll see GERD, forward head posture, and the breath is not silent. The breath should always be silent. Whenever somebody breathes in and out, it should be quiet. So if you sit down to talk to a patient and you hear them breathing in and out hard, you know that there's something going on that's not normal. A raspy voice, too, is one to look for. Like they talk like they got cigarettes. That's the GERD. So, another thing is people who sleep next to a snorer. They'll have aches and pains, fatigue, daytime sleepiness, fibromyalgia, depression, memory impairment, sexual dysfunction, weight gain, all the things very similar to a patient with obstructive sleep apnea, except they're just being awakened by the snoring or the flopping around or whatever the person with the sleep apnea is doing at night. So it's a problem. It's the reason why they tend to move into separate beds. Sleep apnea, let's draw a circle around that. That's what we talk about the most, but really it starts off as airflow restriction, and that moves into sleep apnea as the patient ages and the body becomes more damaged. As the body becomes even more damaged, it'll move into hypoventilation, and it'll move into Cheyne-Stokes respiration. We'll talk about those a little bit later. So, what does it look like? This is a normal person on the left, and a person with a smaller airway on the right. You'll see the smaller airway. You also notice that the hyoid bone is pointing more toward the genial tubercles on the one on the left and more up on the one on the right. So it is more horizontal in a person with a smaller airway than it is with a person with a normal airway. So the swallowing difficulty is normal on the one on the right. The one on the left tends to swallow normally and breathe relatively normally. You'll look at the pattern. I like the Minolta 300i in Patient Safety Software. This is the pattern that comes off of that if somebody is normal. You'll notice the top is the oxygen or SpO2, that's the blue line. The green line is the heart rate, and both of them should remain calm. That's the way it's supposed to be. However, if you see someone with obstructive sleep apnea like this patient, the top graph indicates what they were like before treatment. And you can see the drop in the oxygen. You can see that the oxygen is going below 90%. You see the incredibly active heart rate. But after treatment, you'll notice that the heart rate tends to calm down and the oxygen tends to be much less of a problem. You'll see the two dips in the middle, but you'll notice that that's a motion artifact. The Minolta 300i in patient safety software tends to be able to, it can pick up movement because there's an actigraph in the oximeter itself, and it screens out movement and air within the pulse oximetry. That's always been the problem with oximetry because it's prone to error, and that's the reason why physicians do not regard it very highly. But the patient safety and Minolta 300i are incredibly accurate. If you look at this is from Dental Clinics of North America 2012. You'll notice that the sympathetic nervous system tends to ramp up. That's the top graph, the blue graph, and as it ramps up, you'll see that the patient has the arousal. That's the next one down below. As it gets more and more sympathetic intervention, the arousal occurs. You'll see that the tachycardia increases too on the ECG. That's because the release of epinephrine. Prior to the full-blown event, you'll see that there's an increased jaw opening activity. Those are the suprahyoids, infrahyoids. They're tightening up to pull the epiglottis and the hyoid bone forward. You'll see the blood pressure ramps up a little bit later, but the next thing, the masseter right, masseter left, I find very interesting because at the height of the arousal, the masseters contract along with the suprahyoids and infrahyoids. And what that does, it tends to pull the hyoid bone forward and clear the airway. This is hypoventilation. It comes because the patient can't breathe correctly. There's so much fat inside the chest cavity that the lungs have no place to go. There's just absolutely no room for ventilation, and so the person will take a large breath, and the next breath will be smaller and smaller and smaller and smaller until they gasp again. And so you'll see the pattern of the SpO2 tends to look like a wave. So that's classic for hypoventilation, and there's just no room for the lungs. A patient should go through a normal sleep architecture. This is what I was talking about earlier. You start off awake and you move down into stage 1, which is barely asleep. 2 is light sleep. 3 and 4 are deep sleep or delta or slow wave. Many people have combined 3 and 4 and drop 4 and just call it stage 3 or delta or slow wave sleep because it's hard to differentiate between the two. The red on this is REM, and you'll notice that the REM occurs more toward the end of the night than it does at the beginning of the night. You'll see that the delta or slow wave sleep occurs more at the beginning of the night than at the end of the night. And so that's a normal sleep architecture with 1 or 2 awakenings. You see those at about 4 hours and then again at about 6 hours. Now, if you take the hypnogram of a person with upper airway resistance, where they're being continually aroused, you'll notice that the delta or slow wave sleep goes away. There's a lot of stage 1, stage 2 sleep. REM is fragmented. It can be anything. In this case, it's more toward the beginning of the night, it's toward the end of the night. You'll see multiple awakenings. That's what you call fragmented sleep, and that's a problem. This graph is the metabolic stress syndrome. I'd recommend reading about it and looking it up on the internet. Just Google it and you'll find a lot about metabolic stress syndrome. But the big thing is down here in the bottom left-hand corner, intermittent hypoxia. That's where the oxygen just goes up and down, up and down, up and down with the patient, and that's what is considered to be the cause of most of the problems. But you really should go over that insulin resistance and spend some time to really understand this graph. I just put it in so you'll know to remember to do that. Stroke. It's one of the biggest things that cause people to go forward with treatment, because 68% of all people that have had a stroke also have sleep apnea. You can't say the apnea caused the stroke, but they occur together. There's been cases, there's a racial difference here. This is Caucasian norms, and if you look at the Asian norms, that is as high as in the high 80s, low 90s as far as stroke goes. So the incidence of stroke is something that just scares people to death, because it should. It's a problem. They become debilitated. They're depending on others. And you need to let people know that they run that risk if they have uncontrolled sleep disordered breathing or sleep apnea. There's many other diseases that occur along with sleep apnea. They're the comorbidities. Take a look at these and all the percentages that are there. I show this to patients all the time, from congestive heart failure to severe obesity, drug-resistant hypertension. That means they need at least 2 drugs to maintain. Atrial fib is a big one. Stroke, depression, metabolic stress syndrome we've already talked about. And then the last one is Wisconsin cohort study. This is men 30 to 60 years old, men and women, over an 18-year period of time. And basically, if they have an apnea-hypopnea index of less than 5, their probability of living 18 more years is about 96%. And it goes all the way down to an apnea index of greater than 30. Their probability of living 18 more years is only 57%. So the incidence of death rates is considerably higher with more severe apnea. We do know for sure that severe sleep apnea does kill people. So the natural history of a generic disease, this just ramps up. I believe it starts off with tonsils and adenoids. It's a progression into TMD. It'll move into type 2 diabetes, hypertension, and finally into full-blown obstructive sleep apnea. And it's just a progression, and it takes time. This is the curve for any disease, not just obstructive sleep apnea, but I feel it makes the point very well. Heavy snoring significantly increases the risk of carotid artery arteriosclerosis. In other words, just the fact of snoring is a problem of creating plaque in the carotid artery. The people have said that it's because you're vibrating the carotid artery so much that it causes plaque to form. The other thing that I would say about that is it contradicts. People call things simple snoring. And anybody that calls snoring simple, I heard a man, one of the researchers say, is simple. So the idea that somebody is simple snoring and it's benign is not the case. It is an independent risk factor for arteriosclerosis. This is how the body works. There's basically 4 compartments: the lung, arterial compartment, tissue compartment, and the venous compartment. And the blood circulates from the lungs to the arterioles and back around. And so when we're measuring it with a pulse oximeter, we're actually measuring the arterial component, which is where the oxygen should be the best. Actually, most oxygen in the body is stored in the tissue compartment and in the venous compartment. So when you see a decrease in the arterial, the tissue and the venous have already been severely deprived of oxygen. So you're starting to see a real problem when pulse oximetry drops that low. Going back to more morbidity, this was a study done in 1988, and it shows men 40 to 50 are very much at risk. And if the apnea index, they didn't call it hypopnea, it's just the apnea index of greater than 20 and less than 20. If someone had an apnea index of less than 20, this is their probability of survival. If it's greater than 20, the incidence of death was much higher. But I did really wonder about that, so I just put numbers to it. So that meant that 4 out of 37 died before they were 50 years old. So that's a significant number of people. And so you need to test men between 40 and 50. They're a very high risk group. There's been a good bit of research done that shows that women are too, especially in their 30s. If they tend to have high apnea indexes, the incidence of death is much higher. And when a young man or woman dies in their sleep, you can bet that it was sleep apnea. The next thing I like to show parents is tonsils and adenoids. This has to do a lot with ADHD. That's the beginning of the curve on the generic disease that I talked about earlier. You remove the tonsils and adenoids and there's a more free-flowing air. So the body isn't stimulated as much with epinephrine, so the child gets better sleep, feels better, does better in school. There's been a lot of study done on that. If it's removal of tonsils and adenoids and the child is still of normal size, it's as high as 80% actually remission of ADHD if the tonsils and adenoids are removed. If the child is heavy and overweight, it's about a 20% reduction in ADHD. The next is the two appliances I use for controlling of TMD. One is the anterior appliance and the other is the pivotal. I get high compliance, but I want to stress that even though these work very well and I've used them for a lot of years, we move directly into a Herbst appliance as soon as the patient is stabilized with the TMD. Once they have been screened and you see whether there's a problem with upper airway resistance or there isn't. And if they start to have sleep disorder breathing, the correct thing is to move them into a Herbst or a sleep appliance and not stay on a bite plane. This is my flow chart for that. Basically, it's with a leaf gauge. You bite down on a leaf gauge or a cotton roll and make sure all the posterior teeth are separated. The patient slides forward, falls back, bites down in near-centric relation. You have them bite for about 4 to 7 minutes. And what will happen is you'll create the pain if somebody is a TMD patient. If the pain it can be duplicated, I feel that you can get rid of it. The pain goes into two different categories. One that occurs pretty much almost immediately within 30 to 60 seconds, and when they let up with pressure, the pain continues to radiate. That tends to be a joint, and the muscle will come in about 4.5 to 5 minutes, and when they let up on it, it tends to go away. The last one is a sleepiness that shows, I get a lot of pushback on people because they say, well, I'm not sleepy. Well, what this shows is it's over 4,000 patients from Pittsburgh in the sleep clinic there. And the red line going down the middle horizontally shows above that people were sleepy, below that they're not. This is the Epworth Sleepiness Scale. And you'll notice that the AHI or apnea-hypopnea index can be extreme, clear out in the hundreds, and they will not have any daytime sleepiness. On the contrary, you can have somebody with literally an AHI of 0 and have extreme sleepiness. That gets into the individuality of the person. So the idea that whether somebody is daytime sleepy or not daytime sleepy doesn't really matter much. I feel those patients should be screened. I personally use a Minolta 300i, and if it shows any incidence of apnea, then we refer to a sleep physician for diagnosis of obstructive sleep apnea and treat accordingly. So thank you for listening. I carry this with me, and if you have any questions, feel free to give me an email. Thank you.